Good morning, everyone. We warmly welcome you to another episode of the Weekly Sunday webinar series organized by the Society for Health Research and Innovation, Knowledge Academy. Before moving on to the lecture, let me walk you through some of the rules. The webinar will be available from 9 a.m. to 9:50 a.m. After that, no late attendees will be entertained. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points to adhere to the NCCPD guidelines. We have implemented these regulations to improve and maintain the standards of the CPD programs conducted by the Society for Health Research and Innovation. We thank you for your kind adherence and compliance to these rules and regulations. There will be a question time at the end of each webinar. You can type your questions in the chat function, and we will be asking your questions at the end of the webinar as time permits. If you have any specific questions or your question could not be answered, you can always email us your questions to office330@gmail.com. Moving on to the lecture, today we will be talking about common pediatric emergencies, identification and management. And we will be talking about pyloric stenosis and acute scrotum in children. Today, our speaker is Dr. Balasubramaniam Sayanthan. He's a consultant pediatric surgeon and lecturer at the University of Jaffna with a fellowship in pediatric surgery from Waikato Hospital in New Zealand. He has over a decade of clinical and academic experience and specializes in pediatric surgical emergencies and trauma management. Over to you, sir.
Thank you, Dari. Good morning, all of you. So today I'm going to take my second part of the lecture. This is also two important topics we plan to cover. First, I would like to cover the acute scrotum. This is one of the common condition, as well as if we attend immediately, the outcome will be very expected things. That's mean very good outcome. So I would like to touch first acute scrotum. If time permits, I will touch the second topic also. We'll go to the slides now. Right. I will start my lecture with one case presentation. So this is a 9-year-old boy, previously healthy, presented to the emergency department, accompanied by his distressed parents. So the parents reported that their son had complained of sudden onset of severe scrotal pain 36 hours ago, which worsened progressively. Notably, the onset of symptoms coincide with the return of their son from a camping trip with friends. The parents recounted that their son had initially dismissed the discomfort, attributing it to possible strain from physical activities during camping. That was a real scenario I faced. So this son, that particular boy, he went to a trip with his friends. Actually, that was organized by the school. So he was alone, but there without parents. So he was with the guidance of other colleagues as well as seniors. So he got the pain 36 hours early, and he was denied because he felt that is due to some physical activities. So he didn't tell his friends initially. And when he returned from the camping only, he told their parents. So parents got upset, and immediately they have taken the kid to the hospital. Just this is one scenario. We will discuss the outcome later, but this is one case presentation. You see, we know the acute scrotal pain in pediatric patient is a challenging presentation because the pediatric age group from neonatal period onwards, we are handling up to 16 years. So this sort of age group, bigger kids, they will clearly explain their signs and symptoms. But if you take 6-month-old baby, 1-year-old babies, they cannot explain properly. So they will only cry always. So we have the challenges to diagnose this condition. So one thing is their time frame is important, because if you want to do a proper examination and proper history taking, that is one of the challenge. Second thing, we need to immediately take the decision without delay. We need to do the surgical management. That is another challenge. So our main aim, time is here important. So we need to think about the timing. So timing is a crucial factor. That's why I put the case above. Everyone knows the basic anatomy of the testis. So testis is a male reproductive organ that is located inside the scrotum. Just having some covering. You can see in this picture, there are some covering layers. Inside the covering, the blood circulations are there. Mainly, they are getting blood circulation from testicular arteries and artery to ductus and cremastic artery. So these are the main supply for the testicular vessels. 3 blood supply, as well as veins are there, pemphidiform plexus. So everything's coming through the spermatic cord. That's an important key factor, because if there any twist in this spermatic cord, all the blood supply will cut off. So that is the thing. It will get ischemia, and finally it will get necrosis. So there are many reasons for torsion. I will go through one by one. This is a main anatomical appearance you can see here. Another important thing you need to see here. This is one of the important anatomical defect that will facilitate the testicular torsion. Everyone knows bell clapper deformity. Why this bell clapper deformity will happen? You see here, tunica vaginalis attachment. If it attaching high, like a high riding attachment, it will help to twist in between. So automatically the lie of the testis will be in abnormal position and it will try to twist. So due to the twisting, it will lose the blood supply. Testicular torsion also can be 2 types. One is intravaginal torsion, that is commonly happening in the bigger kids and just after the neonatal period, commonly it will happen. Sometimes intravaginal torsion is happening in the big kids. Extravaginal torsion also possible. That is commonly happening during the baby, that's been neonatal period. Intrauterine life, that is possible. So you can see intrauterine life, that is possible. That is called extravaginal. I will go through the summary slides. You can clearly understand. Now you see the picture. The bell clapper deformity is due to abnormal attachment of the tunica vaginalis. That is the exam question also. You concentrate on that. If you see one patient with testicular pain, in your mind, many questions will happen. First important diagnosis is torsion, because that is very much crucial to suspect torsion to prevent the necrosis. Otherwise, you will think all the diagnosis except torsion. You will keep the child and ongoing investigation will happen. Finally, the time frame will be beyond your survival time of the testis. So always think first priority, testicular torsion. Other causes also can mimic like testicular torsion. What are those? Epididymitis. That means inflammation of the epididymis of the testis. Other one is torsion of the appendix testis. So torsion of the appendix testis also mimics similar, but the severity will be less. But unfortunately, the patient cannot explain properly, because their individual pain feeling factors are different and their perceptions are different. So we cannot exactly differentiate the testicular torsion with appendicular testis. Trauma possible. Trauma can be only with the testicular injury, or sometimes it will associated with testicular torsion. So traumatic testis also, we need to have eye on testicular torsion. Inguinal hernia, usually painless, but if it obstructed or incarcerated, strangulated, it will cause pain. Strangulated inguinal hernia, it will cause pain and swelling in the testicular area and groin area. So mainly always we need to think about differential diagnosis. First one is testicular torsion. Always we need to think cross-scrotal pain. Second, epididymitis, torsion of the appendicular testis, trauma, inguinal hernia, strangulated. So these are the things you need to always think. So clinical presentation, when you see the clinical presentation, you know the testicular torsion will happen immediately. So sudden onset of pain will be there. Swelling, erythema will come little later. Due to the autonomic nervous system involvement, patient will have nausea, vomiting. So patient may present with nausea, vomiting, sudden onset of pain. Sometimes these kids will present only abdominal pain. So they will come and tell, I have a right side low abdominal pain. Sometimes they will tell left side low abdominal pain. Always we need to check the genitalia. Never forget to do genital examination with all the kids with abdominal pain. So always you need to think testicular pain patient sometimes come and present like abdominal pain. So history and physical examinations are very much important. And urgency in assessment and management is also important. So as a proper history, you need to go through the time of onset and always document the time of onset because that is important for the prognosis. Because why I am repeatedly telling the time because the 6 hours is very much important. If we lose the first 6 hours, we will end up in disaster. So always abdominal pain patients, always do the examination of the genitalia. Especially medical students, you need to know in your exam, always abdominal pain, you need to ask the examiner, I would like to do the genital examination. Otherwise, you will lose some marks. So already I said about history taking. Second thing, physical examination. Physical examination, as usual, inspection, palpation, you are doing. Here, inspection, you will see the particular site of the testis will be swelling and it may have some erythema and sometime it will be in higher up than other normal sites. If you ask to stand up the boy or kid, so you can observe that particular torsion side will be little high up compared to the other side. And you can see some erythematous and swelling in particular site. Another important thing, if you elevate the affected testis, in epidermolysis, it will relieve the pain. But in the testicular torsion, they will feel more pain. That means if you elevate the testis of the tortured patient, the testicular pain will be aggravated by the elevation. But in epidermolysis, other way. You see epidermolysis inflammation. So if you elevate, that will release the pain. That's called Pern sign. Another important physical sign you can do, cremastic reflex. If you stroke the inner part of the thigh, because of the normal cremastic reflex, that particular testis will move upwards. Suppose if not moved upwards, that's one of the sign for the torsion. Because you know already the cremaster and everything twisted. So there's no chance to pull upwards. So that is the important thing. So 2 things you can do here. Always check the normal side testis also. Sometimes that side may be undescended testis. So everything you need to clearly document it. So when you are examining the abnormal side, same time you need to examine the normal side also. Then only you can document properly. You know, always in our setup, we don't have immediate scan facilities. It may take few hours, sometime few days. So because of facilities, never wait for any ultrasound scan. If you feel that is testicular torsion, even midnight, 1 a.m., immediately arrange the exploration. Here, don't think about fasting. Don't think about any other things, because if you wait for another couple of hours, you will lose the testis. That is permanent damage for the patients. Never wait for ultrasound scan, never wait for fasting. You have rights to ask the theater immediately and do the surgery. So that is the only way you can save the testis. Even if you explore epidermolysis, that is also not a harm. You can thoroughly wash out and you can come back. If you see appendicular testis torsion, don't worry. Remove that. That will release the pain. So testicular pain patients always do scrotal exploration. If you have a minor doubt also, don't wait for investigations. But other ways, some of the countries, they may have facilities in ultrasound scan, on the spot diagnosis. If you have, you can get. But mainly that will help to differentiate between epidermolysis and testicular torsion. But clinical decision making and exploration is the best option. In exam point of view also, medical students do need to write in that way. Never write about ultrasound scan. But if you have any facilities, or second option, the patient presented after 30 hours, 36 hours, you have the ultrasound scan facilities, you can request them. Because already time gone. So if you wait another 30 minutes, that will not affect the patient's testicular lifespan. Because if you in the critical period, like 3 hours, 4 hours, never wait for any other investigations. Straightforward theater. Even don't do any blood investigation, wait. Not necessary. So already I told about the reason for bell clapper deformity. You can see clearly in this picture. And testicular torsion already we explained, so you need to think about. You can see in other side testis also, most of the time they will have a bell clapper deformity. That's why usually when we are doing surgical exploration, same time we are fixing other side to prevent the torsion of other side, because same thing happen to other side also in future. That's why when you are preparing the patient, always get a concern to fix other side. When you're working as a house officer, always we need to get the concern to fix other side. And always testicular patients get the concern for orchidectomy. If it gangrenous testis, we need to do orchidectomy. So that is important. Second thing, exploration, other side important. Always we need to explain the parents. Otherwise, parents will confuse and they will blame us. We have done the wrong side surgery also. Always be alert. So there are various researches articles about this testicular torsion. It's one of the interesting research published in urology. So they have done exploration and for the approximately 80 patients. They found 70 had torsion, 12 had 70 had appendicular testis torsion among them. 12 had torsion of the testicle. So that is an important thing. So you can see the ratio. So any testicular pain they are exploring, they found 70 patients had appendicular testis torsion only. Other 12 had torsion of the testicle. So here you can note, if it no torsion, you don't want to, if it no testicular torsion, you don't want to fix other side. Because here only appendicular testis torsion. So other side testis torsion risk also minimal. So you don't want to fix other side. You can just remove the appendicular testis and come back. And in these patients, 7 had other pathologies like hernia, varicocele, and idiopathic scrotal edema also. Some of them had 11 patients had epidermolysis. That's mainly due to E. coli and other urinary tract pathogens. So so in this article, every testicular pain patient, they explored. They don't want to take any risk on this I already explained. So this is a little bit summary. You see, testicular torsion can happen any age. Intrauterine life also it's possible. And actually perinatal torsion, 10%, 90% after the neonatal period. So first you can think 10% happen in the perinatal period, 90% after that. That means beyond the neonatal period. Mainly happen in adolescent period, maybe 12 years, 13, 15, that sort of age. Testicular volume will increase quickly, heaviness will increase quickly. That time their supportive attachment will be less strength. So that time they have more chance to torsion. Second thing, if you specifically see the perinatal torsion, 2/3 happen prenatal, before birth. 1/3 will happen postnatal. 2/3 prenatal, again 1/3 postnatal. If you take what are the types happening in this perinatal period, again 90% extravaginal. So that's a neonatal period. Commonest type is extravaginal torsion. Clearly see here. But intravaginal also can happen. For your MCQ point, if they mention intravaginal torsion can happen in neonatal period, that also true. But commonly happen extravaginal torsion. But beyond the neonatal period, always intravaginal torsion. That is the important thing you need to know. But exceptions are there, but commonly happening intravaginal torsion. So you can see the picture. Intravaginal torsion first I have shown. You see the vaginal attachment, tunica vaginal attachment is very high. So within that, the torsion will happen here. So that is the important thing you can see here. Right. Second thing, you can see here, this is extravaginal torsion. This is commonly happening in the intrauterine life or perinatal period, mainly intrauterine life. That's mean before birth. Another third rare type, long mesochium. That means here this is a mesochium. You can see the arrow mark. This area they can twist. This is also another third type, but this not common, so that's why we are not bothering too much. But this is also possible. For your exam point of view, you need to know. But in the adolescent period, usually this will happen. So commonly happening thing is intravaginal torsion. But neonatal period or in intrauterine life, this is common. 90% this will happen. This may be rare, but you need to know long mesochium, also one of the cause. So already I explained these things, so I will skip this slide. So already I said what is the reason for the intravaginal torsion, extravaginal torsion. This is a summary of the evaluation arm. You can see here. First, perform history and physical examination. Consistent with torsion and pain less than 6 hours, immediate surgical exposure. But questionable diagnosis, that means very mild pain. Patient may have fever with some different presentation like dysuria, fever, and mild pain in the testis or something. You can just little bit think about do some ultrasound scan, but that pain should be more than 6 hours. Don't take any risk within 6 hours because that's a golden period. But if it more than 6 hours means sometime 1 day pain, 2 day pain, even if it torsion already testis is gone. So that patient, if you suspect some different diagnosis, you may perform ultrasound color Doppler. That's mean called duplex. But your exam point of view, forget this part. Mainly you always think about exploration, all the testicular pain. Even 12 hours, 24 hours, first you think exploration. Second thing, if you have facilities, if you suspect some other different diagnosis only, mainly you may need to do some blood test. sorry, ultrasound test. Ultrasound will show increased blood flow in epidermolysis because of the inflammation. But absence of blood circulation, again torsion, immediate surgery. So that's important. You can see some pictures. So 6 to 8 hours, within 6 to 8 hours, you may have chance to recover the testis almost near 100%. If it beyond that means beyond 12 hours, maybe 0%. But in partial torsions also possible. Partial torsions, the testis will survive more than the 12 hours. That means degree of the torsion is also important. The twist, we can count the degree. Maybe 360 degrees, sometimes 2 twists, 3 twists possible. So if it more twist, that ischemia will be more. So anyhow, don't take any risk. Better to do exploration for all the testicular pain, even midnight. You can see here the testis color. So what do you think? The testis is black. That means ischemia maybe long time than 6 hours. But all the testis, we will untwist the twist. Then we will wait for few minutes, minimum 15 minutes at least. Then we can again recheck the color. If we recheck the color, that will be good. We are also happy. We can fix it. So we need to de-twist the torsion. How we will do? Because testicular torsion always twists towards the midline. If you take the left testis, that will twist anti-clockwise. So when we do detorsion, we will do clockwise. That means easy way you can remember, close your book, that is the torsion. Open your book, again detorsion. So you see right hand side, which direction you need to open, left hand side, which direction you need to open. Easy way to remember, open the book. So doctor should do open the book. That similar appearance, similar mechanism you need to apply to the testis also. So if you see the patient, you always think about open the book. Left side testis, you need to do open the book in a clockwise. Right side, anti-clockwise. So you can easy to remember that. Open the book. Okay, so that is important. When you have some facilities to do ultrasound scan, you will find like this. You see the center part of the testicular area, you will not see the blood circulation. You can see here, center part of the area, no colors. That means no blood circulation, but peripheral, some surrounding structures they may have. So this ultrasound indicates testicular torsion. If it in epidermolysis, many red color, blue color dots you will see here. So that is the important thing in testicular torsion. But torsion, we don't want to wait for ultrasound scan, but unfortunately or fortunately, if you have done scan, you can see this sort of appearance. Another differential diagnosis, already I mentioned, epidermitis. Epidermitis is inflammation of the epidermis. You see, this is the epidermis. Here you see this is inflamed. Red color, swelling is there. So this is also mimic as a testicular torsion. Usually epidermis start gradually and it will take slow onset of process. But in pediatric population, in young kids, we cannot immediately exclude the torsion and epidermitis because that is difficult. But here, urinary symptoms may be possible and fever possible, tenderness possible. So these are the possibilities there. But management wise, antibiotics, scrotal support, that is helpful. So if you have a clear diagnosis about epidermis, and you can do ultrasound scan, you can see the high blood flow circulation. But if you have any doubt, don't worry about exploration. Explore it and wash out this area because it's an inflammation. It may have exudates, pus within this cavity. So you can do exploration, wash out, and close it. So that will also help to cure the condition, as well as you need to give the antibiotics. Another important diagnosis, torsion of the appendix testis or epididymis. So this also mimic like torsion of the testis, but less severe. But fair skin people, you can see blue dot sign. If you see the scrotal skin, if they are in foreign people, fair skin people, through the skin, you can see dark color dot. So that is called as blue dot sign. But in dark skin people, that is difficult to see. But sometimes when you do clinical examination, you can feel little bit tiny peanut size painful lump. So even if you have confident diagnosis, you can manage conservatively without doing exploration, but the pain take time to settle. They may have sometime inflammatory fluids collection, severe pain, and it will not settle with normal ordinary paracetamol or some basic pain medication. You may need to do surgical exploration to cure the pain. So if you have any doubt, don't worry. Do exploration and remove that appendicular testis and come back. In that particular condition, you don't want to fix the testis because this is not real torsion. This patient will not have bell clapper deformity also. If you see bell clapper deformity, you can fix it. Another condition I already mentioned, trauma of the testis. These young boys are very active. They will jump here and there. They may get sometime trauma. Cycle bar and some monkey bar exercise, they will jump here and there. They will get lacerations. In addition to that, don't ignore this patient because you need to do proper examination of the patient. If possible, do it under anesthesia. Because when you do scrotal exploration or repair for this patient, better to explore and see the testis. Because sometimes you may miss the torsion in addition to the trauma. Because trauma also one of the precipitating factor for the torsion. Sometimes you may think only skin laceration, you will switch. Patient may think because of the laceration and laceration only, they have pain. They may miss sometime testicular torsion. So thoroughly examine. And if you have any doubt, explore and thoroughly wash out particular area and close it. Sometimes hematoma will be there. Very superficial laceration. If you have clear clinical examination findings, you can leave that. Only switch the skin. Otherwise, better to explore and clearly do the work without doubt. Another important thing, it will also important in day-to-day practice as well as exam point of view, inguinal hernia. Inguinal hernia also in kids present with similar pain and features of strangulation. So don't ignore if you have any clinical diagnosis, doubtful conditions, you can do the scan also. Otherwise, inguinal hernia, always clinical diagnosis. You can do clinical examination. You can see here, groin swelling. So the particular groin swelling, you need to observe because testicular torsion, groin swelling will not happen. But this particular patients, this you can see particular groin swelling. So clearly you can see here swelling in this particular region. You can see the aroma here. I am moving here. This is a redness due to strangulation. This is the area of the swelling. So here management is different. You cannot do the scrotal exploration. You need to do the inguinal incision and you need to manage. Clearly I can see this thing, okay? I will check the time. If time permits, we can go. I think we have time, enough time. So we can go other topic also. So we will discuss this part. After that, you can ask the question. So there are enough time to ask questions. So I will go to the second topic also. And after that, we will go through the question. So second topic is infantile hypertrophic pyloric stenosis. That is another important topic in pediatric population. So management point of view, that is important. Here, I just want to touch introduction, epidemiology, etiology, clinical manifestation, diagnosis, complication, and management summary reference. So these are the things I need to touch. Introduction, infantile hypertrophic pyloric stenosis is a condition of hypertrophy of the pylorus. You know the parts of the stomach, I will see, along with elongation and thickening of eventually progress to near complete obstruction of the gastric outlet. This is the basic anatomy of the stomach. You can see here. This is part of the stomach, fundus, body of the stomach. This is cardinal orifice of the stomach, pyloric sphincter, pyloric canal, pyloric antrum. So gastric walls, everything is there. So here, this is the area we are focusing in this part. So this is the pyloric sphincter. Okay, so this area will be hypertrophy and elongate. Because of that, the food particles will obstruct here. So if the baby drink milk, it will come and accumulate here. It will not go beyond this part. So beyond this pyloric part. So certain hours later, the food will be again vomited by the baby. That means milk will be come out like a projectile vomiting. So that is one of the important signs of pyloric stenosis. So if you see the epidemiology, actually the incidence 1 to 3 in 1,000 infants in USA, commonly in white, less common in blacks, rare in Asians. So compared to foreign, we are the lucky people. We have less common things. If you see the males-female ratio, males are more common. So males are more common. Second thing, yes, there are family histories, hereditary. So if the mother had this pyloric stenosis, they will have more chance to get pyloric stenosis. So that is an important thing. Common in infant with B blood group or blood group. So that is very important. I already gave the question the last time also. What is the typical age of onset of pyloric stenosis? So this is a common thing you need to know. The answer is 3 to 5 weeks. So 3 to 5 weeks time, this particular will be happen. So that is the important thing you need to know. 3 to 5 weeks that will happen. Etiology, when you see the etiology, the majority of the cases in the is idiopathic. So multifactorial. But other things also we can synthesis, diminished nitric oxide synthesis, because nitric oxide will act as a relaxation of the muscles. Neonatal hypergastrinemia and gastric hyperacidity, increased prostaglandins, environmental factors like macrolides, antibiotics, particularly erythromycin, will be the one of the causative factor. So if the mother use this thing in pregnancy time, it will be effective. So we need to consider these are the risk factors. But you need to know majority of the causes are idiopathic. We don't know the basic etiology. But sometimes these are the possible things we are thinking. Pyloric stenosis. So important thing you need to know associated abnormalities. So maybe eosinophilic gastroenteritis, Apert syndrome, trisomy 18, mid-gut malrotation, hypercania, congenital heart disease. These are the possible associated anomalies with pyloric stenosis. For your MCQ, sometimes you may get these sort of things. Eosinophilic gastroenteritis, Apert syndrome, trisomy, mid-gut malrotation, hypercania, congenital heart disease. You know the clinical manifestations. The baby otherwise well, usually babies well, they will start vomiting in early neonatal period. Maybe second week, third week, they will start to vomit. So this will happen sometime later also, but commonly this will happen around 5 weeks, 4 weeks time. That vomits are non-bilious vomits because you know the block is in the pyloric region. So bile cannot come back to stomach. That's why the milk will be come as a milk. That means they will vomit milky vomits without bile stain. Why projectile? Because outflow obstruction is there. Stomach is full. Stomach will suddenly vigorously contract. So the baby will push all the milk out. Projectile vomits. Second thing, progressively getting worse. That means first day they will vomit one time, sometimes second day, 2, 3 times. Gradually it will worse. So mom will consider this usually. After vomit, you know the baby is again hungry. So they won't feed. Again they will cry. They will drink a lot because of hungry. Again it will vomit. So obviously weight loss will be there. Obviously dehydration will be there because this milk will not absorb. That's why obviously weight loss as well as dehydration. So you know how to check the dehydration. One is skin tegger. Skin tegger will be low. Second thing, fontanelle you can check. Mucosa membranes, everything will be dry. And urine output will be low. So these are the features you need to always consider with pyloric stenosis. Because some kids overfeeding also can cause vomiting. That mom also, first primary moms, they are very anxious. So they will come to you with the vomiting child. So that baby will be gradually getting weight, well-looking baby, not a typical projectile vomiting that may have vomiting, but not projectile vomiting. But mom will come and always tell the vomit's very big. So you always think about pyloric stenosis. When you check the weight chart, you will see the weight is going upwards, up and up. So that is giving good justification for you. And moms will say the baby will pass adequate urine. When you examine the baby's skin turgor will be good, fontanelle will be good, mucosal membrane will be wet. So you can assume the baby is adequately hydrated and getting weight. So that may be due to overfeeding by the mom. That's one of the chance. Another thing is there. Sometimes some kids will come bilious vomiting. Don't think that is pyloric stenosis because bilious vomiting is dangerous in kids. We never expect to see the green color vomiting in kids. That should be having some serious surgical conditions. That may be midgut volvulus, some other abnormalities in the bowels. So never take easy as a bilious vomiting. Bilious vomiting is a dangerous sign in pediatrics. But pyloric stenosis is always non-bilious vomiting. So now you know clinical manifestations. The age group is very early age, maybe 4-5 weeks. Non-bilious vomiting. That should be projectile. Projectile means it should come very forcefully through the mouth and nose. So through the mouth and nose, it will come very forcefully. And these symptoms will get worse and worse. That means progressively worsen vomiting. And after every vomiting, child start to cry. The baby will cry because of hungry. So mom will again feed, again it will vomit. Weight loss, dehydration, important signs. So already I have touched something, dehydration, underweight I already told, abdominal distension, sometimes you can see due to distended stomach. Obvious gastric peristalsis wave you can see from left to right. And that's a test feeding you can give. You can ask to feed the child by mom, and you can observe the stomach try to push the milk towards the duodenum. But unfortunately, it will not happen. Then only it will come back again through the mouth and nose. Olive-sized mass you can feel sometime. If the patient is emaciated, little later presentation, patient abdomen will be scaphoid shape. That means already patient is emaciated. So you can easily see the olive-like mass. The olive-sized mass you can palpate in the right upper abdomen, lateral to abdominal, rectus abdominal muscles. So this is a gastric peristalsis. Just you can see the obvious stomach is moving. So when you do the investigations, mainly investigation and management, first management part also I will tell. Here, you know, obviously stomach is not working. That means stomach is blocked. So whatever you are feeding through the stomach will not absorb. So you need to rehydrate the patient and correct the electrolytes through the intravenous lines. So first important thing, hydrate the patient with intravenous lines. Second thing, to prevent the vomiting, put the NG tube, nasogastric tube. So first you are going to give the IV fluids, IV lines, and same time when you are putting the IV lines, collect the blood for basic investigations. Mainly here we are expecting blood pH as well as serum electrolytes and iron-base balance. That means blood gas analysis is important. So, and blood sugar you can check. Your main aim, you need to hydrate the patient and correct the electrolytes. Then do the further investigation, supportive investigations, and do the surgery. You know, the important imaging study is ultrasound scan. That is more than enough to diagnose the pyloric stenosis. Don't want to do other special investigations. Ultrasound scan abdomen is more than enough. Experienced radiologist can diagnose even more than 95%. Even 99, they can diagnose if they are having good experience. So you are going to check the pyloric muscles thickness, pyloric canal thickness, pyloric muscles length. So this is a cutoff point, 4 millimeter muscle thickness, diameter you need to check, and muscles length you need to check. And if you have anything, you can just do additionally like barium swallow or barium meals. Sorry, barium meal. But that also not necessary. Usually ultrasound is more than enough. Suppose if you have done barium meal, filling defect will be there, shoulder sign will be there, beak sign will be there, double track sign. So these are the features you can find in barium meal. But ultrasound scan is more than enough. Suppose if you have done another abdominal X-ray, you can see delayed gastric emptying, peristalsis waves, elongated pylorus with narrow lumen, and sting sign. which may be appears duplicated due to occurring of the mucosa, double track sign. So these, if you have good experience, sometimes you can find these sort of features, but ultrasound scan is more than enough. So this is the barium meals appearance. So you can see here shorter sign, double track sign, and big sign, but that is not commonly we are not doing this thing. So you may ask, what are the differential diagnoses for pyloric stenosis? So GERD, gastroesophageal reflux disease, sometimes the babies vomits after feeding. That is one thing. Gastric volvulus will be there, gastric webs, gastric duplication, congenital adrenal hyperplasia, due to that they can vomit, pyelonephritis, foreign bodies. So many reasons for vomits. So many reasons for vomits, but the typical features suggest for pyloric stenosis. With ultrasound scan, you can come to the diagnosis. Because even pyelonephritis infection also babies can vomit. But depending on the clinical features and examination history, you can come to the diagnosis. That is not very difficult. You can easily come to the diagnosis. You know the complications. Already I told, dehydration and hypovolemic shock possible, because patient is not taking anything, or that's mean taking but not absorbing anything. So dehydration, hypovolemic shock is important. Electrolyte acid space disturbance, malnutrition, sometimes due to dehydration, unconjugated hypobilirubinemia are possible. So these are the complications. Management point of view, first thing, prevent the dehydration. And second, correct the electrolytes disturbance and surgery. So first, we know IV fluids important, get the IV line is important, then start the IV fluids. Sodium chloride, normal saline, that means 0.9% sodium chloride is adequate for this hydration, and you may need to add KCl, because potassium sometimes necessary to replace. That's why you need to frequently check the electrolytes. According to that, you need to add the KCl also. But sodium chloride, if you start, that's immediately, that's good. Additionally, you can add potassium chloride. And correct the electrolytes disturbance. So you are going to check the electrolytes and you are going to correct according to that. When you correct these things, automatically the pH will be correct itself. So that is important thing. And finally, you need to think about the surgical management, because until correction of the electrolytes, we cannot do the surgery. That is not safe, because if we give anesthesia, that is giving trouble to the baby. So always first we need to correct the electrolytes, correct the electrolytes and pH. Then only we can go to surgery. So maybe it's take 24 hours, sometimes 36 hours, we need to wait. But we need to hydrate the patient, we need to correct the electrolytes, then only we can go to the surgery. Until that, we need to keep the baby nil by mouth. That is important thing. Surgery called Ramstead pyloromyotomy. We can do it by laparoscopically and open technique also, depending on the facilities. So that is very simple surgery. So our main thing, see, surgically, we just want to cut the muscles, not mucosa. So we are just cutting the muscles layer by the laparoscopic method or open method. After that, we will leave the mucosa intact. So after surgery, after for a few hours, maybe 3 to 4 hours later, we can give some saline and we can observe the baby. The saline will tolerate. After that, gradually we can start the feeding. But again, 1 or 2 days, patient may have vomiting. Don't get panic. That is a usual thing. After this, because this baby was vomiting after feeding for a long time, maybe 2-3 weeks, a similar habit will happen later also, because some edema will be there in the surgical side, partial obstruction will be there. So it will take time to settle, maybe 3 days, 5 days, sometimes weeks. But gradually the severity will be go down. So don't think if the baby vomits that surgery was not successful. That's the important thing. It will take time to settle. As a summary, infantile hypertrophic pyloric stenosis commonly affect first-born male babies. Second thing, present with non-bilious vomiting after second week of life, maybe third, fourth, fifth week. Eager to feed after vomiting because of hungry. Gastric peristalsis will be noticeable in some kids. Ultrasound is sensitive more than 95% to check the thickness and diameter. Pyloromyotomy is the surgical management important. Other than that, correction of the electrolytes, dehydration is very much important. So that is important before surgery. So this is the basic things. So I think we have a few minutes to ask some questions. So anyone wants to ask any question, please ask. Thank you.
So there are a few questions in the chat box.
Yes.
Is there a difference in management of extravaginal and intravaginal torsion?
Actually, surgical point of view, our main thing, we need to explore the scrotum without delay. That is the first thing. Then we will fix the testis, whatever we usually fix the testis. We don't want to take any risk. Most of the time, management point of view, we are just doing same principle because we are exploring and check the viability and fix the same side testis and fix opposite side testis. We are approaching through the scrotal incision. That's the important thing. Right. Thank you. Next question.
What is the first line antibiotic for epididymocarditis and the duration of antibiotics?
Yeah, that's a good question because you see epidermocarditis, we usually suspecting epidermocarditis, we usually take the urine for culture also. So in the local hospital policies and local microbiology team advice, we need to actually change the antibiotics later. But beforehand, if you think E. coli, there is a urine pathogens, we need to cover the gram-negative bacteria. So we need to give oral antibiotics, even broad spectrum antibiotic we can start. Broad spectrum, even you can start with coamoxiclav, you can start, or some cotrimoxazole you can start, depending on the severity. Suppose if you want to start IV antibiotics, you can choose differently, but usually 7 to 10 days we need to treat until completely cure the disease. Minimum 7 days you need to give. Sometime if urine is still positive, if still signs are there, you need to continue. But depending on the severity, you can choose the oral as well as IV. If it's very severe, tender, better to give antibiotics IV. So within that days, you can get a proper culture report. When third day, fourth day, you can get. So check the resistance and local antibiotic policy. You can start. Thank you.
So if we find an appendicular torsion in testis during exploration, isn't it wise to fix both sides? And if we fix both sides, are there any complications occurring later?
Actually, appendicular testis torsion only if we find, we will not fix. We only remove appendicular testis and the total appendicular testis. And if we find some other appendicular testis without torsion also, we will remove that also and we will come back. We will not fix the testis because there's a normal chances of getting torsion equal to other populations. The other population we are not fixing, no. So that's why same principle, we are not doing any exploration for other side.
So there's another question. After the fixation of testicular torsion, how can we follow up a patient?
Yes, that's good question. So usually we are nowadays we are using all the absorbable switches. We don't want to remove switches or anything, but usually we will give the review in third day, fifth day, like that.
Sir, are there any long-term outcomes for children who undergo surgery for testicular torsion, and how does that impact fertility?
Yes, that also another important question actually. Thank you very much for asking. Testicular torsion, usually if we fixed within 6 hours, we hope that will work as normal testis. Suppose sometime very equivocal situation also we are fixing. That means sometime around 12 hours, some testis looks normal. That testis we will not remove. That testis also we are fixing. That testis may sometime not work. And sometime it may produce sometime antibody reactions. It may breach the blood testicular barrier. Sometime it will cause antibody reaction. It may affect the fertility in future. But long-term studies are not available in this subject. We may need to do further investigation. So always tell the patients, if it less than 6 hours, reassure them. Usually it will not cause much problem. Because you see, all the patients with testicular problem or not, 50% of the fertility issues are in males. If you take many of them with azoospermia, they don't have any testicular surgery. They are very healthy people. They don't have any surgeries. But even though they have issues. So that means you can understand, even without doing any testicular surgery, that patient also having azoospermia and fertility issues. Even same incidents happen in every patient. When testicular surgery or not, it will happen. You can understand, I think. Thank you.
So there's another question. What is the best suture material for the fixation of the testes?
Right. So depending on the surgeons, actually, myself, I prefer absorbable, because if we fix with absorbable, that is very convenient for the patient, because after certain time, it will permanently fix. That means theory is like that. When we one time open and close the testicular coverings, it will cause adhesions and it will fix. So short term only, we need to fix with the absorbable material. Later, the fibrosis will do that work itself. So absorbable, I usually prefer monocrel 50, because small kids 50 is fine. 50 round body monocrel we can use. If not, some people, I have seen some seniors, my colleagues, they are using Vigral also. Even still, some of them are using Prolene. That's operator dependent. But myself, I prefer monocrel, because monocrel is monofilament. It will have less chance to get infection. I prefer monocrel 50 for 2 years, 3 years, 5 years kids, maybe 40 for the big kids, maybe 12 years, 13 years, we can use 40 monocrel. Thank you.
So there's one more question. Are there any preventative measures we can advise patients to stop the recurrence of this testicular torsion?
Actually, testicular torsion, they cannot prevent, because the young kids will be very active. They will jump, they will run here and there. They may have getting trauma also. Ideally, if they want to prevent, they can avoid the trauma unnecessary. Second thing, if you first time, if they present, that's the first time and last time, because you are going to fix it. You are going to fix it. They will never get torsion. Because if you have done proper surgery, that patient will never get torsion again. So that's only one episode only they will present, first episode. If they have testicular torsion in the first episode, doctor will do fixation on that side and other side also. So after that, they will not get any torsion, because already fixed that. Thank you.
Thank you, sir. That's all for the questions. We thank you sincerely for your very informative and interactive lecture. We thank Dr. Balasubramaniam Sayanthan, the consultant pediatric surgeon and the lecturer of the University of Jaffna, for this very excellent lecture and your time spent on teaching us.
Thank you very much. Great help. Actually, I like to teach you all again and again. Thank you very much. Thanks.
So there's a link in the chat box for your CPD certificate. You can kindly give your feedback and answer the post-assessment questions, and then you can receive your e-certificate for participation. If you have any specific questions, you can always email them to office313@gmail.com or the CPD WhatsApp group. Thank you very much for your participation.
Thank you very much.